Holly Tomlin, and I am a research fellow at Well Cornell Medicine and a doctoral student at Meharry Medical College. And today I will be presenting prioritizing poverty by related laws and policies to evaluate diabetes development in the regards cohort. I have no disclosures to report. I want to first, of course, acknowledge and thank my co-authors, including Dr. Monica Safford and Faisal Khan, who are my primary mentors. So to give you a little bit of background, what we did is looked at both legal and cardiovascular epidemiology. We understand already that social and structural inequities on cardiometabolic disorders lead to more morbidity and mortality across the U.S. with measurable differences by race, class, and gender. But few studies have examined specific laws that perpetuate inequities and poverty, a key antecedent to disease development. Here, we operationalize a legal epidemiologic model to examine the impact of poverty-related state laws on diabetes development after 10 years in the national biracial cohort of the regards study. So, state law and policy reinforce structural and social inequities. And what we did here is we took a framework from the legal epidemiology text from Professor Burris's group and evaluated law and policy on health outcomes with social and economic inequities as a mediating factor. Poverty is a social and economic inequity that is expressed differently for different races, particularly for Black compared to white people. In this preliminary analysis, we measure 6 laws in particular related to income and economic stability on poor health outcomes, and we test our hypothesis stratified by race. So the hypothesis is that individuals who reside in a state with protective or inclusionary poverty-related legal index scores are less likely to develop diabetes over 10 years compared to individuals who reside in a state with discriminatory or exclusionary poverty-related legal index scores. First, we constructed the cohort from a national biracial cohort of over 30,000 Black and white participants above the age of 45. Who were community residents of the 48 contiguous U.S. states plus Washington, D.C. We oversampled for the stroke belt and stroke buckle in the Southeast, and the main focus of the parent study was racial and geographic differences in stroke mortality. Our sample consisted of regards participants without diabetes at baseline, and the outcome was the presence of diabetes at the 10-year visit confirmed by self-report, treatment with oral diabetes medicine or insulin, glucose levels, and hemoglobin A1C more than 6.4%. And the exposure variable was the poverty-related legal index. Specifically, in constructing the exposure variable, we looked at 6 laws related to minimum wage, predatory lending, and earned income tax credit. The table that you see before you was constructed originally by Professor Ajnor and Professor Needham's group. And what they did is they scored the laws based on protective inclusionary, which received a -1, or discriminatory exclusionary, which received a +1. And I know this is a little bit counterintuitive, but think of it as if they do not discriminate, then it's -1. If they do discriminate, then it is a +1. The baseline covariates were region, state proportion of Black residents, gender, age, individual social position, cardiovascular disease clinical risk factors at baseline, and cardiovascular disease behavioral risk factors. Our methods consisted of constructing a state-level poverty-related index by averaging scores for 2010 through 2013. We compared baseline characteristics and ultimately constructed a multivariable logistic regression models. And lastly, we tested interactions by gender and age. So we started with 30,239 participants, and we were able to evaluate 13,373 participants who had a second in-home visit. There were 15 states that had more discriminatory laws, and 34 states, including Washington, D.C., that had more protective laws than discriminatory laws. These are heat maps that show on the left the state law total score, and then on the right you see the frequency of diabetes by state. What we had was more Black participants develop diabetes than white participants, but more white participants lived in states that had exclusionary and discriminatory laws. The Black participants lived in, they were stratified equally between states that had protective and discriminatory versus, protective and inclusionary laws versus discriminatory versus exclusionary laws. The odds of developing diabetes was 4% for each 1 point increase in poverty-related state law score for Black participants in the unadjusted model, but not for white participants in the unadjusted model. And the fully adjusted models, neither the Black or white participants show statistical significance. There were, of course, limitations to our study. Law enactment dates are unknown, therefore the impact of the laws on diabetes development must be interpreted with caution. The poverty index only includes assessment from 2010 to 2013, therefore more longitudinal exposure assessment may be required to better reflect lifetime exposure to laws. Of course, people drop in and out of the employment market, thus exposure to existing laws related to income and economic stability may vary at the individual level. That is, those in the labor market are more exposed than those who are not. In conclusions, minimum wage, predatory lending, earned income tax laws were selected because of their relationship to income and economic stability. A legal index of 6 laws related to poverty significantly predicted odds of diabetes development for Black but not for white participants. This association was attenuated with addition of covariates to the model. Therefore, the association may have been due to differences in characteristics of participants in states with more and less discriminatory laws. We are evaluating this effect. A more granular assessment of longitudinal exposure to these laws may be warranted. The public health implications include a state-level poverty-related index is an upstream factor in the mechanistic pathway between law, poverty, and diabetes development. The effect of poverty on disease development is a complex interplay between structural and social determinants of health over time. And a more longitudinal assessment of state laws may better explain the cumulative effect on poverty and in turn, progression to chronic diseases like diabetes. And so these are a list of my references. They're pretty extensive because of the cross-cutting impact of law policy with poverty. Thank you very much for your time.
I even have my 3-inch heels on here, and it doesn't do me a whole lot of good behind this.
I've done a lot of biological work as well. That's where I did a lot of. I'm going to make it fun. My colleague at
but now I've been
He's kind of like having a rigorous approach that helps to organize. Because when we have the law talk about like the next steps, and things. So I think if no one asks any questions, moderator, I would have thought that we have this.
Pleasure to meet you.
What is it? What does it look like? What are the limitations? Pretty great conversation. And it's like, if you know these are all the things that work, like this working
Think about that. That's a great Thank you. Lovely to meet you. And you did a great job.